The time is now noon, our official start time, noon Eastern. So I'd like to kick it off for today. First of all, thank you so much for joining us for today's Physician Leadership Network webinar, Quality Reporting, Implications for Value-Based Purchasing. Your host for today's event is Dr. Adrienne Mims, and your facilitator, Dr. Kim Rask. I am Jennifer Hurley with Aqua. I am going to be providing the welcome message and housekeeping, and providing support on the back end. Our faculty for today's event: Mary Cox, Suzanne Dalton, Kathy Pritchard, and Melody Brown. So without further ado, I'd like to turn things over to your host today, Dr. Adrienne Mims.
Thank you, Jen. And I'd like to extend a warm welcome to all of you who are logged into us onto the webinar, and those of you who are on the phone but who have not logged into the webinar. We're very excited to have you participate with us here today. We have an exciting presentation to discuss value-based purchasing. Those of you who have joined us previously realize that this is a series of webinars that we've been doing, or we call them clinical discussions. These were all born out from the Physician Leadership Network, which is a group of physicians within the quality improvement structure nationally. We are housed as a group within AQUA, who is our trade association. We include physicians from every QIO, from any role within those QIOs, to be involved in these discussions. Early on, we realized that it would be of value to share some best practices and have an opportunity to host a dialogue, question and answer around areas that we find important in our work that may be extended on into the 11th scope of work. We find that it's important to share and have an open communication, not just with the physicians, but those of you who practice with us from various disciplines. So I'm going to put a poll up here, and you'll see the poll in your right-hand box. And it's three questions there. I'd like to get your feedback. We know that we have extended the sessions to be with a larger group of people who are part of the QIO community who are not just physicians. We wanted to ensure that we have analysts, outreach people, and also CMS have been invited. So we'd like for you to fill in the poll that you'll see listed there to let us know that you're participating. In addition to that, since we've been hosting these sessions, we realized that it's of value to have a cross-section of people by discipline. Hence the third question that you see listed there. We want to know, how involved are you prior to the session in value-based purchasing? I myself, this is not one of my expert content areas, so I put in here that I'm not personally involved, but I'm very interested in learning more. So when the poll is closed, we'll get some feedback on what the results of that is a little bit later on. But it is important that we use time together to share information. Many of you may be joining us next week as we go to the Aqua Quality Conference, which will be in Baltimore. At that time, I'll be starting as the president of Aqua, and it will be exciting to begin to work to increase the visibility of all of the work that we're doing in the field on a national level. We'll be working to ensure that the providers, the Medicare beneficiaries, and the other stakeholder organizations are fully aware of what we are capable of providing as members of the QIO across the nation. So if the poll is closed, I'd like to see the results here as we go on and move forward to introducing the next speaker. Today we have as our facilitator one of my colleagues here in Alliant GMCF, Dr. Kimberly Rask. She's an internist, and she's also a health economist at the Emory School of Public Health. Kim, I'll turn it over to you. I see the poll has come up, and great. We have quite a good distribution of people on the line today, and a lot of us are new learners to this field. Kim, I'll turn it over to you.
Thank you, Adrian, and good morning or good afternoon, depending on what time zone you all are in. We really appreciate you joining us today for this discussion. I am pleased to see the range of people who are here, both in terms of their background as well as how involved they currently are with value-based purchasing and the more general topic of quality reporting. This is becoming really an increasing part of the work of all of our providers and by extension the work that we do as a QIO, and this is a great opportunity to talk about this, think about what we've learned so far, and then think about what are some of the things that we could do better going forward or what might be some opportunities to move the work that we do in step with the needs of our providers. For me personally, I've worked in performance measurement and outcome measurement for a long time, so this whole topic area is very near and dear to my heart. And if you look at the title today, we're talking about quality reporting implications for value-based purchasing. As you know, value-based purchasing is not part of the QIO contract. However, quality reporting has long been part of the QIO community work, and we have a lot of years of experience across the QIO community supporting hospitals with their quality reporting programs. And over this time, we've had opportunities where our QIO initiatives have related to CMS priorities that might be voluntary participation on the part of hospitals, and we've learned the techniques and approaches for being able to identify and work with willing workers. And we've also had the reporting priorities, and that gives us a different way to be able to reach and support hospitals. In the work in the 9th and 10th scope of work around quality reporting, we've seen our hospitals have to learn new measures, new data sources, new data collection strategies, and new population measures. And across the QIO community, I believe that we've learned a lot about how to do this work effectively, and today is going to give us an opportunity to see some of these lessons and talk about where we think we can go going forward. If we look at today's agenda, we hope to cover a lot of these pieces. First, we're going to do an overview of the reporting system. Mary Cox is going to kind of talk us through at a high level the alphabet soup of inpatient and outpatient reporting and the relationship to value-based purchasing. After she speaks, we will open it up for questions, and I remind you of the chat function that's available on the webinar, and I encourage you to enter questions in the chat even during her presentation as they occur to you, and then we will stop and look at those questions and let her respond to them after the presentation. After that program overview, we're going to move to 3 QIO presentations. Suzanne Dalton, Kathy Pritchard, and Mel Brown will each share with us some of the experiences that they've had and successes that they've had with quality reporting programs in their states. And then after the 3 presentations, we will again open it up for questions to the panelists. And again, I remind you of the chat function. Feel free to ask questions in the chat section while each presenter is presenting, and we will note those and make sure that they get responded to at the end. And then lastly, we're going to have an open discussion with our panelists as well as our participants on what we see as the opportunities for QIO support of healthcare providers moving forward under value-based purchasing programs. And that will kind of give us an opportunity to move from where we are today to best practices, to challenges, to opportunities for the future. So I'm really looking forward to this call today, and I hope that you all will too, and I would encourage your active participation. As Jen mentioned, we are providing CME credits for this, so we have learning objectives, and the learning objectives, as you can see here, are that following today's presentation, we expect participants will be better prepared to describe the differences in current reporting programs, be able to discuss how current reporting programs relate to value-based purchasing, be able to identify one critical success factor that can be applied to your work, identify one challenge faced by participating hospitals that can be addressed by your work, And finally, that you will be able to apply this information to your professional practice. So to move to our first presentation, an overview of the reporting programs. Our first presenter is Mary Cox, a nurse who is director of the CMS National Hospital Inpatient Quality Reporting Program at Telegen. As you can see, she has been at Telegen since 1985 and has a lot of national hospital reporting program experience, including MDS, OASIS, and Hospital Compare. Mary, welcome to our webinar, and we look forward to hearing your presentation.
Thank you. Welcome to everyone on the call, and I'm very happy to hopefully help you wade through some of the acronyms of the program. First slide, please. The Inpatient Quality Reporting Program began early in the 2000s. The initial acronym was RACTPU, which stood for Reporting Hospital Quality Data for Annual Payment Update. It was and still is a voluntary program. It does, however, have payment consequences if they don't choose to voluntarily report. The purpose is to equip consumers with quality of care information to make more informed decisions about their own health care, while encouraging hospitals and clinicians to improve the quality of inpatient care provided to all patients. This is a reporting program. When we say all patients, hospitals are to report for all patients of all payers that fall into the measure set, not just Medicare recipients. 2 or 3 years ago, the acronym was determined to be difficult, and it made sense to align inpatient and outpatient. So RACTPU was retired and replaced with the term Hospital Inpatient Quality Reporting Program. We oftentimes call it just simply IQR. And as you will see on a later slide, you have IQR and you have OQR. So it did simplify the acronym quite a lot, and it really spoke more clearly as to who the involved parties were. Next slide, please. The hospital IQR program began in fiscal year 2005. For inpatients, the fiscal year is based on October 1st through September 30th. When the fiscal year 2005 began, it actually involved data that were collected during the calendar year 2004. And I can tell you that the timelines and the dates and the years can become, they can be very difficult for people to get straight in their heads. So I really encourage everyone to stop and think that, you know, your fiscal year is what's going forward. It's either what you were in today or going forward to, while the calendar year that involves that is approximately 2 years prior to that. So the rules and citations are here on this slide. It began with 2005 and 2007. The payment reduction was a 0.04 percentage point for the annual payment update to hospitals. The Deficit Reduction Act of 2005 increased that, so that actually for 2007 fiscal year, the reduction was 2 percentage points for hospitals that do not participate by choice, or that 2 percentage point reduction to the annual payment update has not increased or decreased since that fiscal year. Next slide. The outpatient program actually mirrors the inpatient program in many respects. The purpose for outpatient reporting is to provide hospitals, again, with a financial incentive to report their quality of care measures data and to provide CMS with data to help Medicare beneficiaries make more informed decisions about their health care. The original name for the outpatient program was HOPQDROP, and that stood for Hospital Outpatient Payment Quality Data Reporting. And as I had mentioned earlier, at the same time that inpatient changed to IQR, outpatient changed to OQR. So the acronyms became much shorter and friendlier to use. Next slide. As I said, OQR is modeled after the current hospital IQR program. That does not mean that OQR does everything the same way as IQR, nor does it mean IQR does everything the same way as OQR. Both of the programs have learned a good deal from each other. IQR has implemented some changes based on OQR's practices that were found to be very good, or vice versa. The OQR program was mandated by the Tax Relief Act and Healthcare Act of 2006 to affect payments, and you'll notice here, beginning calendar year 2009. So OQR runs calendar years. IQR runs fiscal years. For OQR, non-submission results in a 2 percentage point reduction in their annual payment update. So the next question is, which hospitals are involved in this? When we think of inpatient, I don't know about you, but I think of all hospitals as being inpatient. We're looking at subsection D hospitals. This is just kind of I tried to abbreviate it down from the actual rule definition of subsection D hospitals. If hospitals located in one of the 50 states or the District of Columbia, that excludes the U.S. territories. The Virgin Islands, Puerto Rico, those are excluded. It also excludes psychiatric hospitals as defined in 1861F. It excludes rehabilitation hospitals as defined by the Secretary. It excludes hospitals whose inpatients are predominantly individuals under 18 years of age, so that excludes most of your children's hospitals. Hospitals designated long-term acute care hospitals, hospitals designated critical access hospitals, and those hospitals recognized as comprehensive cancer centers or clinical cancer research centers. I can tell you that this last one was confusing in the beginning because there are a number of hospitals that are predominantly cancer treatment hospitals. However, there are only 11 that meet this exclusion for inpatient and outpatient. And those 11 are now reporting under a different initiative. Please note that for inpatient reporting, Indian Health Service hospitals are included, and for outpatient, they are not required to report. Next slide. So what about those hospitals, those critical access hospitals, those Indian Health Service hospitals for the outpatient? They want to participate. They want to have data, and they want to improve quality of care, as well as the short-term acute care hospitals do. So for inpatient, those that I didn't already talk about as being subsection D, those hospitals that are excluded from being eligible for the IQR program, they can voluntarily submit data, and it can be publicly reported on the Hospital Compare website. This is where a few of the differences between inpatient and outpatient come in. For inpatient, critical access hospitals, children's hospitals, those 11 cancer hospitals, they can submit their data in for inpatient without signing any kind of a pledge or participation form. However, none of their data will be provided back to them on preview reports, and none of it would be reported on Hospital Compare. If they want preview reports quarterly, and they want the opportunity to have their data published on Hospital Compare, they do have to sign a pledge to participate. For inpatient, they can sign that document at any time during the year. There's no particular registration or sign-up time. They do have to designate what date they are beginning, what discharges they're beginning their reporting from. They will have the opportunity to preview their data and then determine if they want it published on Hospital Compare. They can withhold any or all of the data. They can withhold one measure from being reported if they want. Most hospitals do go ahead and have it reported. We have very few that withhold data. So that's kind of anybody that wants to report inpatient can do so. If they don't have a notice that they're participating and will not get that quarterly preview report, and they don't have the opportunity for Hospital Compare. Next slide. Outpatient is different. If hospitals are not part of the IPBS reporting, it is saying they can voluntarily submit and they can be publicly reported. They have a certain time frame each year that they can pledge during, and they can have data previewed if they are submitting their data, but they have to make the decision on whether they want their data published on Hospital Compare at the time that they're pledging. So that gives the volunteers, the voluntary reporters, two options. They must make that choice during that time that they're signing it. They have the option to voluntarily submit data, and it's automatically published on Hospital Compare. They do get the preview report, so they'll know what their data look like, but they cannot withhold it at that point. The other option is that they are voluntarily submitting data for quality improvement only. So their data are not published on Hospital Compare, but they get the feedback reports from the warehouse to let them know what their measure outcomes are. They can identify some areas that they might have opportunities to improve in the quality of care to meet all of those measures. Next slide. So what do those two programs have to do with value-based purchasing? Currently, outpatient does not have a value-based purchasing program. I'm expecting that will come. Generally, everything that inpatient has done, the next roll around is that outpatient also follows suit. Starting in October of 2012, however, for inpatient, the Medicare began rewarding hospitals that provide high quality of care to their patients. This was established by the Affordable Care Act, and they have an incentive based on how well they perform on each measure or how much they improve in their own performance based on their own baseline period. And the purpose is to promote better clinical outcomes for hospital patients as well as to improve the experience of care during hospital stays. Next slide. On August 1st, 2011, CMS finalized the policies related to hospital value-based purchasing for fiscal year 2013. This program is funded entirely. It's a self-funding program. There is a percent withheld from those hospitals, and then the law requires that total amount that is withheld be redistributed back through payments to those same hospitals at varying levels. Hospitals don't have an opportunity to choose to participate or not participate directly in the VBP program. If they are participating in the IQR program and they receive their full annual payment update, they are automatically eligible in the VBP program. Keep in mind that even though they pass IQR and they're eligible, there are other reasons that they might be excluded down the line. One is that they have 2 or more immediate jeopardy citations in the performance year, during the performance period. Another one is that they maybe don't have enough cases to report. It might be a very small hospital, or their specialty doesn't have cases for the AMI, heart failure, pneumonia, skip, and all of those. So if they don't have enough cases or if they have immediate jeopardy, they're out of the program. But when they're out of the program, they do not have any money withheld. So only if they meet all eligibility requirements does that withhold occur. So hospitals receiving a reduction in IQR for any given fiscal year are automatically not in VBP for that fiscal year, and there is no VBP withhold for that hospital for that fiscal year. So they don't get hit twice, it's only once. Next slide. I put this slide in primarily so that you all would know where the other resources are for more information about these programs. I also included my email, phone number, if you have any direct questions that I can help you with. So with that, I will turn it back over unless there are any questions that I can help you with.
Thank you, Mary, very much for that overview. We really appreciate it. We would like to take a quick break here. If there are any questions from the participants for Mary, specifically about the IQR, OQR, and VBP programs. And first, thank you very much for the simplification of the acronyms. That does make it easier.
And I would say one of the things that I didn't put here is The IQR program support contractor is us here at Telegen. OQR support contractor is FMQAI. So certainly if you have outpatient questions and you want more information, call the outpatient support folks, and they have much more knowledge about that program that I can help you with.
Hi, Kim. Adrian, I did have one question, if you can answer. I'm a little bit more familiar with the inpatient measures, but the outpatient measures, does it cover specific areas in outpatient? Is it ERs, clinics, urgent cares? Is it procedural suites? So which type of areas are covered in the outpatient?
I'm sorry, go ahead.
That was it.
Okay. I believe the majority of them are ER-type treatment questions, like how long was there from arrival to decision to admit. Some of them are particular treatment testing measures, like tests that are frequent to the emergency department. The outpatient group does also have a specifications manual, just as the inpatient does, that lists all of the measures and what the requirements are for abstracting the data for those measures.
Thank you.
Mm-hmm. And this is Kim, and one other difference, I think, in our QIO presenters may bring this up in their discussion further on, is also that many of the, or several of the outpatient measures have a timeliness component. So that's a different kind of quality improvement process than a documentation that a hospital's participation in the value-based purchasing program is dependent first on successfully meeting the inpatient quality reporting program. By analogy then, if a hospital does meet the inpatient quality reporting requirements but does not meet the outpatient quality reporting requirements, are they still eligible for value-based purchasing?
Yes, for the inpatient value-based purchasing, the outpatient reporting doesn't play a role at all. So outpatient at this point is really a standalone over here. Outpatient is also now added on ambulatory surgery center reporting. So when outpatient moves to a value-based purchasing program, when, then the data that are used for the outpatient reporting will be the data that are used for the VBP program. For inpatient, it's the IQR data that are reported that ultimately become the data that's used to determine the hospital's quality performance for the hospital VBP. So they could fail to meet the requirements for outpatient. They meet the requirements for inpatient reporting. They're still in the VBP.
Great. Thank you very much.
Mm-hmm.
It does not appear that we have any other questions at this time. So unless there's another question, we will move on to the QIO presentations. All right, and our first QIO presenter will be Suzanne Dalton, also a nurse, has been in the QIO community since 1999. In the 10th scope of work, she is managing the quality data reporting program and reduction of healthcare-acquired infection initiatives in New Jersey. She also has many years of experience in the hospital setting, which certainly, I'm sure, prepares her very well for her work now in the QI world. Suzanne, thank you for joining us today.
Thank you, Dr. Rask, for your introduction and for your invitation to share a snippet of New Jersey's experience in assisting hospitals in meeting the quality data reporting requirements. Next slide, please. I'm going to introduce you to two new acronyms. IT stands for Infection Preventionist, and PI is Performance Improvement. So besides introducing you to those two new acronyms, New Jersey really wants to focus on the integration of infection preventionists into the performance improvement world. In the 10th scope of work, infection preventionists really had new requirements to report infections, and performance improvement people needed to become familiar with NHSN, which is a CDC database for reporting infections, and also familiarize themselves with infection outcomes. Next slide. So, for many years, New Jersey has dealt with a traditional audience, or so we thought a traditional audience for quality data reporting, and that audience was the performance improvement staff and the process measures that data abstracted. Even though they dealt with AMI, heart failure, pneumonia, SCIP, and other measures as they came upon, it was a very targeted audience, and we believe that we had established very successful avenues of communication to assist them in meeting the requirements. So, as many of the QIOs do, we use newsletters, blast emails for information as well as education. We did large and small group educational sessions relative to validation and passing validation, to new measure sets that evolved over the years, and to the overwhelming number of changes that occurred to the manual as measures are added, subtracted, and or updated. Of course, one-to-one education was also used both on-site, meaning at their place or our place, and through WebExes and conference calls. So next slide. In the 10th scope of work came the reporting of infection measures into NHSN, and it produced a whole new audience of infection preventionists. Some of them may have been involved in pneumonia projects and or SCIP projects, but certainly it was more in intervention than data collection. And some of them had not been involved in quality data reporting at all. So now there's outcome measure reporting, and NHSN has some challenges in itself as a database. One of those challenges is the conferring of rights. It is a very unique way that hospitals have to grant you permission or grant CDC permission to share data with you. So all the hospitals in New Jersey successfully granted rights to HQSI to see their NHSN data. But at the same time, we're a mandatory reporting state, so they had to confer rights to our State Department of Health for the reporting measures that affected them, and some of them were the same as CMS's, and some of them were not the same as CMS's. In the meantime, HQSI got to learn aspects of NHSN. Next slide. My colleague Janet Phillips and I didn't have enough time in a day to do one-to-one education with all the IPs of New Jersey hospitals, so we came up with a plan to fast-track education and integration of IPs into the system. We joined the national APEC and the state chapters as well. We partnered with the state chapters, and there's 2 in New Jersey, to do presentations on hospital quality data reporting and value-based purchasing. Janet and I became standing agenda items for monthly updates at the chapter meetings. We used their listservs to rapidly disseminate information to the members. And remember, the members are not just acute care hospitals. They are all setting hospitals, and NHSN reporting was beginning to move out of acute care into other settings as well. We even became an invited speaker to their annual joint conference of APEC chapters and IDSA in order to talk about value-based purchasing and quality data reporting. So IPs who were masters of NHSN were now becoming novices at learning QualityNet, and PI staff who knew QualityNet were now trying to mentor IPs in the use of QualityNet and also learning some aspects of NHSN. And we, of course, continue to use the successful show you one slide from an educational session, and it takes some of the information that Mary gave you and the history of quality data reporting starting in 2005, and then the path that it takes evolving into value-based purchasing and moving into other years of 2014 and 17. Next slide. We also quickly found out through feedback of hospital staff that the staff were exhibiting a lot of frustration and fatigue with the amount of data reporting they had to do. Some of it for CMS, Joint Commission, as I said, our Department of Health. We have 25 magnet hospitals in New Jersey, so they have reporting to the American Nurses Association. The demands to keep up with the expansion or the constant changes. Now that there's fiscal implications, more attention is being paid to the measure outcomes, and workload certainly increases. So anybody who's worked in quality data reporting over the years has to acknowledge that the measures and the time frames for reporting and keeping it all straight can be mind-boggling. So we knew that we were a recognized resource when the state APEC chapters asked us, HQSI, to put together a simple grid about NHSN reporting as it related to the state of New Jersey. They just wanted a simple visual to know who had to report what measures, for what purpose, at what time, and to whom. So this slide just gives you page 1 of a 3-page document. You see acute care, but it is designed for other provider settings like LTACs and ASCs as they've moved into NHSN reporting. Next slide, please. Now, working with our state APEC chapters has been very successful and rewarding. HQSI staff has learned more about IT monitoring and strategies than we ever thought we would. In the meantime, ITs were learning QI methods and interventions. So our joint successes, we think, have been several. All of our facilities, and we have currently 64 acute care hospitals in the Quality Data Reporting Project. All of them have reported their NHSN measures timely, and that's not just reporting the actual measures, but meeting the required time frames for other kinds of templates involved in validation. We've done it timely despite Superstorm Sandy affecting many of the counties that the hospitals were in. Right after Sandy was a major flu epidemic, as I'm sure other states have experienced. Our EDs were overcrowded, partly from flu and partly because of the aftermath of Superstorm Sandy. And we also had a measles outbreak in the state. But we were timely in quality data reporting. We also saw an expansion of acute care multidisciplines knowledge of quality data reporting. So just as we were getting ITs integrated and understanding this whole system, now one of the requirements for reporting into NHSN is healthcare worker immunizations. So yeah, ITs have access to NHSN, but they may not be the keeper of information about immunizations. So we find out how employee health service all of a sudden is thrust into quality data reporting. Medical staff offices medical staff office in the hospital is probably the one keeping track of the licensed independent practitioners, vaccination records. Volunteers may be in another department. Medical schools may be doing it for their medical students. So all of a sudden, there's many more departments involved in a measure that's going to be publicly reported. Next slide, please. There are many lessons learned that have occurred with NHSN reporting in the past 2 years. And and some of them that we're going to talk about here are that IPs are passionate about what they do. They really want to share the responsibilities and solutions beyond just reporting data. And in many facilities, performance improvement staff and infection prevention staff may have different reporting lines, so they may have intersected at meetings, but not necessarily in a truly integrated manner to accomplish a particular task like quality data reporting. So they now are definitely in need of one another to be successful in meeting the deadlines and measures. Hospitals really need to provide resource support for infection prevention departments. You can imagine it's not unusual to have one infection preventionist in a 250-bed community hospital whose responsibilities include surveillance, education, dealing with outbreaks, consultation to staff in sharing knowledge, and increased data entry. And needless to say, that's not an easy task. And really, they need some support with the actual data entry involved in. One of the best practices that we have in the state, fortunately so, is that some PI directors are also seasoned infection preventionists. And Jenna and I have found that when that occurs, there is truly seamless integration of our quality data reporting, and it has worked out very, very well. Next slide, please. Since there is we also use the 7.1 Reducing HAI Learning and Action Network to push IP and PI integration. Now, our LAN includes APEC chapters, as I talked about, as well as the state chapter of hospital or healthcare quality professionals, our State Hospital Association, and our ESRD network. So the quality professional chapter, working on the land with other disciplines, recognized the importance of reducing HAIs and have devoted their last two annual meetings to HAI reduction and opened up the meetings to infection preventionists. Similarly, the land facilitated the introduction of APEC to the ESRD network, and a partnership has flourished that has led to joint educational sessions for CLAPSI. With the assistance of our hospital association, a grant was obtained from HRET for CUTS training for the dialysis staff. So, again, the goal here is to improve care, and we're trying to integrate as many disciplines and to partners to make that all happen. Next slide, please. It's really been an exciting time in quality data reporting, now moving into value-based purchasing, and it's just the method for improving patient care and patient safety. Our contact information is here, and we thank you for your time and attention.
Thank you, Suzanne. We appreciate your talk. Again, I encourage people, as you have questions, to use the chat function. We will now move on to the next QIO presentation. And our next presenter is Kathy Pritchard, who also has a nursing background and has been working in the QIO community for many years and has many years of hospital quality improvement experience also to bring to this work. Thank you, Kathy.
Thank you, Dr. Rapp. And thank you for giving us the opportunity to talk about our interventions and our successes for the state of Kentucky. The next slide, please. Just to give you a little bit of background about Healthcare Excel in Kentucky. We do have 65 acute care hospitals. We have 29 critical access hospitals. And of the 94 hospitals, 77% of them are in rural communities. And so we really had to be smarter on how to outreach to those all the hospitals and helping them get their data submitted. Healthcare Excel is also the QIO for the state of Indiana, so sharing resources between the states is very helpful. Next slide. It definitely takes a village to ensure that the hospitals get their data in. And so some of the partners that we work with, like Suzanne, we are definitely associated with our APIC, or the Association for Professionals in Infection Control, chapters in the state. And we have presented many times to the local chapters to help educate the infection preventionist staff regarding the HAI measures and what's coming down the pike. Also in Kentucky, we work very closely with the Kentucky Hospital Association, the Kentucky Rural Health Association, and I did list the Indiana Rural Health Association. I'll tell you later on in slides how we tie that together. The University of Louisville School of Public Health and Information Sciences, Kentucky Department of Public Health, and also we work with a multi-state, we collaborate with a multi-state QIO group. We've been doing this for nearly 10 years to help address priorities identified by CMS. Originally, the QIOs that started together was 6 that included Ohio, Indiana, Kentucky, Michigan, Illinois, and Wisconsin. And we found this to be very beneficial, working together in the different statements of work, that we can have continued that. The group has now expanded to 10 QIOs, and Idaho, Iowa, Oregon, and Washington has now been added to the group. The group teleconference monthly, and they also provide education monthly. If CMS has a provider education for that month, they do not provide education, but if there's a month that there isn't, then the QIOs work together to get national speakers to talk to the hospitals that are involved in the HAI group. Next slide. So going through the interventions that we have done in Kentucky that we have found to be helpful, we do send out a Friday update. It is an email blast that goes out to all hospitals. Some of the things that are listed in our Friday update, definitely reminders of upcoming deadlines, data submission deadlines. Any kind of updates or information that CMS has sent out, any kind of education from them, we will provide that in our Friday update. Any other educational information. And also, if there are webinars or teleconferences, we will send out information, invitations through our Friday update to help keep the providers on track of. There's just so much that goes on that helps them keep track of what's coming down the pike. The next slide. Another intervention that we provide is webinars to our providers. And an example of the webinars that we have provided is any kind of specification manual updates. We talk about new measures that, from the final rule, what's coming down the pike, when those new measures are starting to help prepare the hospitals and what they need to do. For example, ensuring that the vendors have right to submit that data for them. It's just an example of the new measures and how to educate our providers. And another one is definitely regarding NHSN, or the National Healthcare Safety Network. When the new HAI measures started in 2011, we quickly realized that in a lot of the hospitals, infection prevention and quality staff do not communicate, and or even in the same department. And although quality has always been involved in quality data reporting, this is new to the infection prevention, and we realized that they had no idea what a final rule meant and what is mandated by CMS, how important that is to their hospitals. So there was a lot of education that had to be done regarding NHSN. The next slide. To help educate the infection prevention staff, and also quality staff was invited, we did a series of NHSM webinars. We had several partners that we worked together to pull these series of webinars together, and we had a national speaker, a consultant from the Surveillance Solutions that did these different webinars for us. I can truly say that this was probably one of our greatest successes to help the infection preventionists to get on board with both the data reporting within NHSN and also tying that together with quality in the quality department. Here's a list of the webinars that we did do for the hospitals in both states. And we also had the same consultant speak at our land meetings because we had such positive feedback regarding this speaker that she was very beneficial in helping to educate our hospitals. The next slide. Another truly success that we have is video recordings. We do work with the Indiana Rural Health Association on these video recordings. They have on their website, it's called Show and Share. And the videos can be recorded and then they're posted on the Show and Share website. So the hospitals can get to that information or those videos at their convenience. Or if they have new staff that's starting within the hospital, they can always refer them back to this Show and Share website that they can view these videos. Our medical director, Howard Schatz, has done the ones that he has recorded are helping to improve your HCAP scores, which is tied directly to value-based purchasing. Also, he's done videos on the new measures, venous thromboembolism, quality measures, CODI, and C. diff infections. Once the recordings are done and posted, then the link is sent out to all the hospitals that they can go out. It is open, it's free to the hospitals that they can go out and view these videos. Another thing that I would like to bring up as far as an intervention is from the files that Intelligence sends us, there is ongoing phone calls to our providers by me, reminding them if they're on a list that something that they haven't submitted or they're under-submitted. It's just ongoing phone calls, and I think that's really important to reach out to the hospitals that this is really necessary to keep them on track as far as ensuring that their data is complete and accurate, and also providing education on what reports to run in QualityNet so that they can follow up themselves to see to ensure that their data is accurate too. And I appreciate the files that is sent to the QIOs because I rely on them in order to reach out to our hospitals. The next slide. So in conclusion, I think that the reason why we've been so successful is because we work directly with our partners, stakeholders, and our providers. We have embraced the all teach, all learn method, especially with our providers and our stakeholders. And I think that's why we have been successful in Kentucky, ensuring that all the hospitals have met their APU requirements. At this time, I'll turn it back over.
Thank you, Kathy. Thank you very much. And now we would like to move to our last QIO presentation, and that will be delivered by Mel Brown from the Georgia QIO, her training is as a medical technologist. She's had years of experience in quality management in rural hospitals, and in her work in the Georgia QIO, we particularly value her experience and relationships with our smaller, rural, and critical access hospitals. Welcome, Mel, and thank you for joining us today.
Thank you, Dr. Rath, for the opportunity to share the work that we are doing in Georgia, and just to be here today with Suzanne and Kathy and listen to what they're doing, the great work that. Slide, please. In Georgia, we have 106 acute care hospitals, 32 critical access hospitals, and here, like everybody else, I'm sure, we do have a very good mix of hospitals with the metropolitan areas as well as the rural mix. Whether the hospitals are acute care or critical access hospitals, it doesn't matter to us. We include them in all of the communication that we are doing and continue to support all of them with all of their efforts and everything that they're doing on their side. And with that, I'd like to share our best practice for today. We were just told recently that we have had 8 years of successful run with our hospitals for receiving their full ATU at the end of the year every year. So we were very proud of that and very proud of the efforts that all of our hospitals are doing in order to make sure that that happens. If I could have the next slide, please. So what do we do to support our hospitals here? Very like Suzanne and Kathy, we have strong relationships with our hospitals. And we do reach out to all different levels in the hospitals with the hospital staff. Primarily, we started with the quality improvement staff, and now that has also gone with the infection preventionists and other support staff that they have in trying to make sure that they meet deadlines and everything that they have to do and have to keep up with now. We are very proud of our strong relationship with our hospital association. We do many things with them, as I will outline in just a minute. And we also have a good, strong relationship with our state Office of Rural Health. Next slide, please. With our hospital association, one of the things that we do, every Monday they have a call called Office Hours, and we co-host with them. This primarily is giving the hospitals the opportunity to network with each other. Again, acute care and critical access hospitals are on the line. We encourage them to participate. One of the things that they have the opportunity to do on these calls is from the week previous to Monday to Monday, they can bring barriers. They can also bring successes. How did they overcome some of the things that were discussed the previous week or that they've come upon this week? We let them bring their questions to the table, and we help with clarification of issues that they may be having with things such as abstraction or even interpretation of the specification manuals and things like that. By invitation, we join them for their bi-yearly statewide meetings, which are currently held in or around the metro Atlanta, and they also try to move the same meeting with the same content to South Georgia to better cover our state and have better participation. And during those times, this is a face-to-face meeting, so it gives the participants not only the time to talk with each other, but to meet each other and build relationships as well as working with us. And part of the educational component of these meetings is to update the participants on quality measures, abstraction changes to the CART tool, QualityNet, make sure that they are remembering their reporting deadlines, and other information that might be pertinent at the time that they will need to be keeping up with. One of the things that we're very proud of is working together to provide some sort of mentorship for our quality people as well as the infection control practitioners out in the state of Georgia with new quality improvement staff as they come on board. If they feel that they need some help, we will try to help network with them with people that we, and along with our hospital association and the Office of Rural Health, have identified as best practices or higher performers. And with their permission, we will provide mentorship to those that might be struggling. Next slide, please. Some of the things that we do in the QIO is we produce a technical alert. This is an electronic newsletter that we send out that will have breaking news on action items or information that needs immediate attention that we have heard from CMS. So this is a way of letting our hospitals know, and they know now whenever they see our logo that we're trying to get information to them, and they are pretty quick to respond to those. We also publish a monthly hospital update, which again is an electronic newsletter, bringing that to them with information, pertinent information that we have found out about. A lot of the information from NHSN this has been the organ that we have used to get the information out to our hospitals. We have an established helpline, phone number for them to call specifically for a hospital, for them to call in with their questions, concerns, or however we may be able to help them. We can do one-on-one webinars as needed. This is most especially helpful for those newcomers that come on board and they may not have any experience in abstraction or submitting data, most especially, so we can do some one-on-one webinars and help them with that. One thing that we have also found in these one-on-one webinars is it's most helpful with our critical access hospitals. A lot of times they do have some challenges with technology and the amount of technology they have in their buildings, and so it just kind of helps to be able to sit there with them and know exactly what they're doing and how they're doing and kind of help them through their barriers and everything. We also support folks with phone calls, emails, and face-to-face at meetings whenever we're able to go out and about to meet with our people. We encourage networking throughout our whole state all the time. So, next slide, please. In doing this, we have one dedicated technical advisor. We do have an infection preventionist on staff who is very active with our state society, the Georgia Infection Prevention Network, and then myself, a quality advisor, working all together to help support our hospitals through their quality measure reporting. Next slide, please. This is our contact information for all three of us that are involved with the state of Georgia. And please, we would encourage folks on the phone if you have questions for us, our infection preventionist, maybe even to connect them with some of the information that Suzanne and Kathy has given us. We'll be glad to speak to that. And then if we could have the last slide, please. As Kathy and Suzanne have mentioned, we're all working together to make healthcare better throughout our state as well as nationwide. And we do thank you for the opportunity today to be able to bring our story of how we work with our hospitals here in Georgia. Is that right?
Thank you, Nell. Thank you for your presentation. Thank you to all of our presenters for sharing your stories and best practices around quality reporting across the QIO community. We would now like to open it up for questions for any participants. And Jen, if you can show just the technological way for people to be able to join the call. You can either use the chat feature, which is on the screen, and as Adrian pointed, you can enter a question into the chat feature or unmute your phone line using *6*. We would like to hear any questions for the presenters, as well as if participants have any success stories of their own that they would like to share at this time, or any tools or resources that you have found particularly helpful for the quality reporting work.
Hi, Kim. I did have one question, and I know a lot of the focus thus far has been on quality reporting, and I'll pose this to any of the presenters or any of the other people on the line. And it is quite a challenge to make sure that everybody's reporting accurately and that their numbers look good. Has there been much work on trying to improve the values of what's being reported? And if anybody can speak to any work that they've done on looking at improvement of the numbers besides just reporting the numbers. Thank you.
This is Kathy, and I will, up until the 10th statement of work, we did focus a lot on their rates and what they look like and helping them to improve their rates. I do work with specifically critical access hospitals and looking at their data and doing face-to-face visits with them to help put processes in place to ensure that their rates look good. I think probably because their denominators are so small. So if they have one fallout, it really can skew the data that they're reflecting. So I think it's important, and I'm sure all the QIOs do look at the data and help them improve their rates because of value-based purchasing.
Suzanne or Mel, any comments on that?
It's Suzanne. One thing that we have found to be helpful is getting a high-performing hospital to, I wouldn't say mentor, but, you know, if we have low-performing hospitals, to try to, in a non-competitive, high-performing hospital, kind of pair them up to see if rates can improve based on some of the strategies the high performer used. But non-competing is the key word here. So they're not necessarily close by in locale, and may have some different culture within the organization.
And this is Melody. I have to agree with this. This is one of the pluses that we have found working with the Hospital Association doing the Monday calls. Not necessarily have we had to do a lot of one-on-one training in this respect, but more of a peer-to-peer informational session, and getting the hospitals online with knowing that, number one, sometimes they feel like we just can't do this. However, when they hear the stories of best practices on these calls, they realize that everybody really can make improvements. And yes, we have seen some successes with that, Dr. Rast.
Thank you. I noticed one question in the chat is whether or not this presentation will be available for sharing as a taped presentation, and it is my understanding that it is being recorded and the slides will be available. One question that I have for the QIO presenters is, in listening to your stories and best practices, there are two themes that came through several times. One of them is the focus on support for new measures. I didn't hear a lot of people talking about what they're doing around core measures. Instead, it's thinking about the new, more challenging infection reporting measures. And then the second theme was working across areas of expertise and perhaps a little bit across aims in terms of infection preventionists who have not traditionally been a part of the quality reporting aim in a QIO. How do you see this working in QIOs, and do you see this as something that going forward QIOs will, in order to do our work effectively, looking within your institution?
This is Melody again from Georgia, and I feel that it's going to be necessary that we do work across aims, and that as we get our message out to the hospitals, that they understand how important it is. I believe either Suzanne or Kathy brought out how important it is now, and had identified the fact that their best performance, I believe it was Suzanne, one of their best performing hospitals has their performance improvement manager is a seasoned IP person. And I think that we're going to see more and more in the future the need for us all to be able to cross over and form a more cohesive relationship throughout the hospital for quality reporting in all the different chasms that we're going to be moving in.
This is Kathy, and as far as we did focus on new measures because, like Mary Cox talked about, the core measures, the basic core measures have been going on since 2005. And so, you know, the hospitals have been working on heart failure, pneumonia, skip, AMI since 2005 and has really moved towards putting those processes in place. So I think that's why we focus on new measures, especially when they're brand new to a different department like infection preventionists and the challenge that we've had working with NHSN. I agree. We really, and we try at Healthcare Excel to work across aims. We definitely do, especially with 7.1 because those hospitals are the same hospitals that fall into quality data reporting. So I do think it's important to work across AIMS and in the QIO community too.
This is Suzanne. I agree with everything that Melanie and Kathy just spoke. I would just like to add an additional, if you look at the new proposed IPPS rule, the process measures are taking, the process measures, meaning the AMI, heart failure, et cetera, are really being retired or suspended, and more emphasis is being placed on the outcome measures, and that's true in value-based purchasing as well. So NHSN becomes more important in quality data reporting flowing into value-based purchasing, because the process measures that will continue will have a less percentage added to the value-based purchasing score. So, if you remember the first year, and geez, help me out, guys, I may be wrong, but the process measures were like 65, 70%. HCAPs were the smaller percent. And now, as the formula for value-based purchasing keeps changing, there's less percentage of the process measures and more of the outcome measures. So, those outcome measures, and I think somebody said very nicely, it takes the community, like in care transitions, it takes the community to bring up your measure rate in order to be successful in value-based purchasing, and all the other penalty programs that are out there, from readmissions to the proposed or potential HAI one, et cetera.
This is Kim. I think that's a great point, and maybe even as we see the work across AIMS right now with the infection preventionists, that as the readmission rates become a larger impact in value-based purchasing, the link between the care transition themes and the quality reporting themes become closer, and there may, again, be a lot of synergy between those groups in order to support hospitals with their value-based purchasing. One other area that you mentioned, the HCAPs, as the HCAPs reporting is becoming a bigger part of value-based purchasing and is a part of the quality reporting contract in this scope of work. Is there, for our QIO presenters, is there anything that you'd like to share about the working with HCAPs?
This is Kathy, and the HCAPS category is very hard. It's hard for hospitals to improve those rates, because it is subjective according to the patient. We've done education. Our medical director, we did do those recordings, but he has also went face-to-face with medical staff on-site at the different hospitals, providing education on both HCAPs and value-based purchasing. I think getting the word out there and what kind of successes or peer-to-peers that the other QIOs we're talking about is important, that they can relay what has worked for them as far as their HCAP scores and improving them.
This is Suzanne. I'm going to say we used our partnership with the Hospital Association even prior to value-based purchasing. The Hospital Association was very, very proactive in providing educational sessions and best practices in HCAP for the hospitals. So, they've got money that we don't have, but they've brought in some real top-notch speakers. So basically, we didn't want to duplicate efforts either. So, we're more the secondary for HCAP, than the hospital association being the primary.
And this is Melody. I think I have to agree with Suzanne with using the hospital association caps and also supporting the hospitals with maybe bringing in outside consultants to help with HCAPs as well.
Hi, it's Adrienne. I would say that some of the HCAPs, which is really looking at the patient's experience of their care, a lot of those questions impact readmission. So this is a prime opportunity to really collaborate with those who are working on C8, because the impact of the patient and their understanding of their discharge process and follow-up, and whether or not they could relate well to the staff and how the staff worked with him has direct implications on readmission.
This is Julie in Pennsylvania. I have another question on a different line for speakers.
Certainly, go ahead.
Everyone spoke about the importance of, all the hand-holding that we do for all of our providers, the messages on Fridays, or the constant contact reminding them of their under submission, and the newsletters and things like that. But we're charged in our contracts with coming up with some sustainability. How can we put some sustainability into what we're doing with our providers? Has anyone started working towards how we can get them to start thinking on their own and doing this on their own? Any plans for the future so that we can spend more time on improving and less time on the hand-holding for the reporting?
This is Kathy. We have not. I'm just hoping that all the education that we're doing and the WebExes and we do, I forgot to mention, we do have a website. Healthcare Excel has a website that we post quality data reporting information out there. I'm interested to find out, too, how people perceive that and how to move forward with sustainability.
Hi, it's Suzanne. Julie, you always pose difficult questions here.
Suzanne, you're the Wonder Woman. Come on.
Oh, yeah, right. How do I want to say this? I think it's such a balancing act for us in terms of quality improvement versus the quote-unquote hand-holding. I really don't know if in this world of competing priorities, that hand-holding would ever go away and have them be as successful as they are today. And I'm not trying to make us indispensable, even though that could happen with sustainability, but and I'm sure it happens to all of you sometimes. I mean, people have done this as long as we have in hospitals, and they know the answers and they know the questions, but they just call because they have to do a reality check because something is happening. Leapfrog is saying one thing, the state's saying another thing. CMS puts out another memo that's non-understandable. And sometimes, we probably should hang a site consultant plaque on the door because they just want to vent and they see us as resources. They want like a one-stop shopping. Give me an answer. Tell me what I need to do because I'm just overwhelmed. And I think that's part of today's reality. Sure, if we all hit the lottery and left tomorrow, would they still be doing it? Sure. Would they be doing it as well? I doubt it.
I agree.
That's my personal opinion.
Yeah, I totally agree with you, Suzanne. I don't, even those that I see that have been doing it well and have needed little input from me are going to have, an outlier in their outpatients or something along those lines where they need the help. There's always going to be a point where they're going to need our help, and I don't see where, that CMS is going to see us going away and having them do this all on their own.
I think that there would be much fewer hospitals getting their annual payment updates as they are now. And sometimes, and as I said, people know the answers, but they're dealing internally with a physician who doesn't believe the measures bill or whatever the case may be, and they come to us as an outsider, because they need to say they consulted, they did this or whatever, and sometimes they also just need an outside look to make sure what they're doing is truly okay. And I don't see anything wrong with that, personally. I mean, we're kind of like mentoring, and it's wonderful.
This is Melody, and Suzanne, I have to agree with you very much so. It's almost like we will need to continue to be that first set of eyes sometime on a problem that they have looked at over and over, and they just want to make sure that they have it right. Here in Georgia, I will say that I have noticed, though, finally, that the CEOs are really taking more of a look at the very importance of quality improvement and infection control. And I don't know about the rest of you, but it's taken a long time to get here.
Thank you. This is Tim. I appreciate all the questions and participation and information sharing from our QIO presenters. With the last few minutes that we have left, I'd like to move to our last kind of closing set of questions. Jen, if you could, yes, thank you. And what I want to take us now that we've kind of looked and shared at where we are today, what we see that our hospitals need, what we see as our ways that we've been able to be successful with hospitals. What I'd like to ask each of the presenters to think about, and anybody else who's participating who has some thoughts about this, is looking at where we are today, looking at where we are likely to be 5 years from now with what's happening with quality reporting moving from the reporting of measures to value-based purchasing where the outcomes of those measures matter. What do hospitals need from our QIOs? What do they need from the QIO community to be able to help them do well and succeed in an increasingly paid-for-performance environment?
I think, this is Kathy, one of the things I hear ongoing, and I'm sure Suzanne and Melody can attest to, is infection preventionists need some kind of cost analysis to prove, because of the data reporting and ongoing addition of the HAI measures, how important it is that that data reporting element, they need help with that.
Thank you. So that's both providing, it's helping to provide the supporting information or resources for them to be able to make that case?
Correct, yes.
It's Suzanne. Yes, it's very hard to build a case for infection prevention, but that old saying, you got to spend some money to save some money. There have been some facilities that have been very successful here in New Jersey, and I'm going to pass the floor in without telling you who, but one of our infection preventionists did a great presentation about environmental services internally, and successfully got additional environmental service people approved, additional keyboards for computers, so that it didn't have to be cleaned or whatever. But she was also, the hospital was featured in a news article, and all of a sudden one day, a Four Seasons hotel called the hospital because they had a permanent resident who wanted his room cleaned like this hospital was cleaning in order to prevent infection in his home, quote, environment. So, yeah, it's very hard to prove, infection prevention business case. And it is necessary at the same point in time. I think it's necessary for CEOs to recognize that infection control or prevention is not with one person or with one department, and that department is as equally as important as radiology or the OR or whatever, and that department really needs to be shored up in resources to meet what lies ahead.
Hi. I thank all of the presenters from today for joining us,